Our next section to discuss is the stomach. A 44-year-old female comes to see you because of epigastric pain that's been bothering her for several months. She denies nausea, vomiting, weight loss, or blood in her stool. On physical exam, you find no abnormalities. The question then posed to you is, what is the most likely diagnosis? Is it A, duodenal ulcer disease, B, gastric ulcer disease, C, gastritis, D, pancreatitis, E, non-ulcer dyspepsia, or F, pancreatic cancer? The correct answer here is E, non-ulcer dyspepsia. This is often a very hard question for students. This is because of the selection bias of which cases you as a student actually get to see at the hospital. Non-ulcer dyspepsia is by far the most common cause of epigastric pain and at a minimum accounts for 50 to 90% of all cases of epigastric pain. This is also true of patients under the age of 50. Therefore, in the hospital, you're going to see far more patients with ulcer disease, pancreatic disorders. Basically, you see the sicker patients. So why am I saying a selection bias? Well, non-ulcer dyspepsia is virtually never a reason to be admitted. Therefore, you'd never see it. But because it's so common, we put it here as a question so you get familiar with it. Now let's go through the wrong answer choices. We know it's not duodenal ulcer disease because there's no anemia or heme-positive stools. If they wanted this, they would give you a hemoglobin, or they would tell you the person's guaiac positive. It's not gastric ulcer disease also because there's no heme-positive stools. Gastritis, you need an EGD to diagnose it. It's really a visual diagnosis with biopsy. You know it's not pancreatitis because this has been going on for several months. If she had pancreatitis for several months, believe me, this would be very significant. Lastly, it's not pancreatic cancer. At 44, it's unlikely, and moreover, she would present with painless jaundice. The USMLE loves abdominal pain. In fact, these questions are very high yield and appear very frequently. Remember, there are 5 major areas on the abdomen you need to know, and you need to know what diseases come from there. So when tackling the question, just start with the location. In the right upper quadrant, you can have cholecystitis. This is a positive Murphy sign. You can have biliary colic or postprandial right upper quadrant pain. Cholangitis is Charcot's triad. It's right upper quadrant pain with fever and jaundice. You can have a perforated duodenal ulcer. Perhaps this patient has H. pylori. In the next quadrant, the left upper quadrant, you can have splenic rupture. This can be due to trauma. You can even have pain from IBS. This is called splenic flexure syndrome. In this syndrome, what happens is gas distends the splenic capsule, and you get pain shortly after eating. In the right lower quadrant, you can have appendicitis, pain that began periumbilically and then moved to the right lower quadrant. It's due to a fecalith obstructing the lumen. You can have ovarian torsion. This is acute, sharp pain that causes you to buckle over in a female who's of reproductive age. You can have ectopic pregnancy. Look for somebody who's had unprotected sex recently and is now missing their menstrual cycle. You can also have cecal diverticulitis, which is rare but can occur. In the left lower quadrant pain, you can have sigmoid volvulus or sigmoid diverticulitis. Look for these in an elderly patient. You can also have ovarian torsion or ectopic pregnancy on this side as well. In the mid-epigastrum, you can have pancreatitis. Look for a patient who's coming in with severe abdominal pain, increases in amylase and lipase. In the history, there'll be alcoholism or gallstones. You can also have aortic dissection. These patients are going to have uncontrolled hypertension. The pain will be ripping, tearing. They may even have unequal blood pressures. Peptic ulcer disease is in those who have NSAID abuse or possibly H. pylori. Now we've gone through 5 different quadrants. Note the different differentials and remember them for the exam. How do you answer the question, what is the most likely diagnosis, when the sole complaint is simply epigastric pain? Well, it's all in the history. If in the history they tell you the pain is worse with food, the most likely diagnosis is gastric ulcer. If they tell you the pain gets better with food, this is a duodenal ulcer from the release of bicarb, relieving the pain. If they tell you, I've had weight loss, they're elderly, it's likely cancer. Or if they have NSAID abuse, it's a gastric ulcer. If they have tenderness and they have a history of gallstones or alcoholism and they have epigastric pain, then it's pancreatitis. If they tell you, I have a bad taste in my mouth, most worse when I lay down, a cough, and I'm hoarse every morning, and they have epigastric pain, it's likely GERD. If they tell you, I've had diabetes for over 20 years, and after I eat, I'm bloating, I have nausea, vomiting, this is gastroparesis. And if they come to you and you say, I have epigastric pain, and you find nothing else, this is non-ulcer dyspepsia. If the epigastric pain is from the stomach, then the most accurate diagnostic test is an endoscopy. It's the only way to truly understand the etiology of epigastric pain if it's coming from ulcer disease. It allows direct visualization and allows you to tell the difference between an ulcer or gastritis. Furthermore, biopsy testing is necessary for a truly precise diagnosis. You need to rule out H. pylori. Remember, radiologic and barium testing are modest in accuracy and they don't let you biopsy. So remember, if you're suspecting an ulcer, do an endoscopy. Proton pump inhibitors are the first-line therapy for someone with epigastric pain. We do it empirically for a period of 4 weeks. If they don't get better, we consider more intervention. H2 blockers such as ranitidine, nizidine, cimetidine, or famotidine are next in line. We don't use them first line because they're not as effective. They only work in about 70% of patients. Liquid antacids have the same efficacy as H2 blockers, but they have rebound acidity and diarrhea. Misoprostol was an artificial prostaglandin analog. We used it to treat NSAID-induced gastric damage, but when PPIs came about, misoprostol became the wrong answer, always. Gastroesophageal reflux disease is an inappropriate relaxation of the lower esophageal sphincter. This results in acid contents of the stomach coming back up into the esophagus and causing pain. The symptoms of GERD are worsened by many foods, such as nicotine, caffeine, peppermint, or eating late-night meals, and there's a high association with obesity. Patients are going to complain of heartburn, metallic taste, a cough that doesn't go away, or morning hoarseness. Remember, there are no unique physical findings in GERD. It's just a complexity of symptoms that you need to know. A 42-year-old male comes to the office with epigastric pain that radiates up into his chest and becomes worse after laying flat for an hour. He also has a brackish taste in his mouth. What is the most appropriate next step in the management of this patient? Is it A, ranitidine, B, a liquid antacid, C, lansoprazole, D, endoscopy, E, barium swallow, or F, 24-hour pH monitoring? The correct answer is lansoprazole, C. It is a PPI that's used to control the symptoms of GERD. When the diagnosis is very clear, such as in this case, there is no confirmatory test necessary. Now let's go through the wrong answer choices. Ranitidine is an H2 blocker. It's not as effective. Liquid antacids are also not as effective and can cause rebound acidity and diarrhea. Endoscopy does not necessarily need to be the first step. You have to fail the first step to have an endoscopy or have alarm symptoms. A barium swallow shows major anatomic abnormalities of the esophagus and is worthless in GERD. 24-hour pH monitoring at this time is not necessary. The diagnosis is clear. 24-hour pH monitoring is the most accurate test. GERD is most often diagnosed using a patient's history. When the history is not clear, then the most accurate test becomes a 24-hour pH monitor. You perform an endoscopy when there are certain alarm symptoms. These are dysphagia or odynophagia, weight loss, anemia or heme-positive stools, and lastly, if it's been more than 5 years of symptoms to exclude Barrett's esophagus. Endoscopy, remember, will show nothing when there's only heartburn. All patients should try lifestyle changes. This includes losing weight, avoiding alcohol, stop smoking, don't eat foods that are triggers, and don't eat within 3 hours of bedtime. Another thing that has been shown to work is elevate the head of your bed 6 to 8 inches. This has actually been clinically proven. For those with mild or intermittent symptoms, you can treat them with liquid antacids or H2 blockers. For those with persistent symptoms or who have erosive esophagitis, they need to be on a PPI for 4 to 6 weeks. 5% of patients will not respond to PPIs. This group will require surgery to tighten the LES. The surgical procedure is called a Nissen fundoplication. This is when the stomach is wrapped around the LES. Endocinch is another option. This is an endoscopically placed suture around the LES to tighten it. The last resort is local heat or radiation to cause scarring of the LES. As I said, this is a last resort. Barrett's esophagus is due to long-standing gastroesophageal reflux disease. The acid exposure causes a change and columnar metaplasia. It takes about 5 years to develop. Each year, about 0.5% of people with Barrett's esophagus will progress to esophageal cancer. That's why it's so important to screen them with an EGD. The diagnosis? It's made by biopsy via endoscopy. This is the only way to assess the presence of Barrett's esophagus. So how do you treat the different findings when screening for Barrett's esophagus? The first finding is Barrett's alone, or simple metaplasia. For these patients, we recommend a PPI and to rescope every 2 to 3 years with biopsies. For those with low-grade dysplasia, we recommend a PPI daily and rescoping every 6 to 12 months. For those who have high-grade dysplasia, they need to have an ablation with endoscopy, photodynamic therapy, a radiofrequency ablation, or surgical removal. In other words, we have to get rid of the high-grade dysplasia. Gastritis is the inflammation or erosion of the gastric lining. It has been also called a gastropathy. There are 3 levels: mild, moderate, or severe, and there are 2 kinds, with or without hemorrhage. So you can have a mild gastropathy without hemorrhage, or a severe gastropathy with hemorrhage. There are many different causes of gastritis. Alcohol can do it, NSAID abuse. Helicobacter pylori infection can also yield gastritis. Portal hypertension will give you something known as portal gastropathy. Stress gastritis can be due to underlying causes such as burns, trauma, sepsis, intubation, or even multi-organ failure due to the uremia that ensues. Atrophic gastritis is associated with vitamin B12 deficiency. Gastritis typically presents with GI bleeding without associated pain. However, severe erosive gastritis can then yield epigastric pain. For these patients, you want to look for NSAIDs or alcoholism in the history. Remember, this type of presentation can have almost any degree of bleeding, from mild coffee ground emesis to large volume vomiting of red blood to simple black stools, which is known as melena. There are no unique physical findings. Therefore, you simply cannot answer the most likely diagnosis question from history and physical alone. When diagnosing gastritis, there are many options, but one stands out. Radiologic studies, such as an upper GI series, will not be specific enough. Although anemia may occur, there are no specific blood tests to tell you the blood is coming out of the stomach. Stool testing may be positive, but again, that does not mean the blood is leaking from the stomach. The most accurate test, therefore, is an EGD, or an esophagogastroduodenoscopy. This is equivalent to an upper endoscopy. It should be combined with H. pylori testing, and if positive, you should be treating these patients. There's an image of H. pylori. One thing for you to keep in mind is that capsule endoscopy is not appropriate for upper GI bleeding if endoscopy is one of the choices. Endoscopy always wins out. Now there are 4 tests for H. pylori, each with its own positives and negatives. The endoscopic biopsy is the most accurate of all tests. It is also the gold standard, but it's also the most invasive as it requires an upper endoscopy. There's serology, a very simple blood test. It's inexpensive. It even excludes infection if the test is negative. This is because it's an IgG. However, that also carries an inherent problem. It lacks specificity. This is because it cannot distinguish between an old and new infection. Remember, IgG is there for life. The urea C13 or C14 breath testing is fantastic. It's positive only in active infection, and it's non-invasive. You simply just need to blow. But the problem is it requires expensive equipment and is not available everywhere. The H. pylori stool antigen test is positive only in active infection, and it's non-invasive. The only cumbersome part is that it requires a stool sample. The mainstay of treatment for gastritis is a PPI. It doesn't matter which PPI, they're all the same. The other forms of treatment, such as H2 blockers, sucralfate, and liquid antacids, aren't as effective as a PPI. Now here's a little tip. Sucralfate is an inert substance. It's made of aluminum hydroxide and it coats the stomach. If it's presented to you as an answer choice, remember it's nearly always the wrong answer for treatment when it comes to gastritis. Stress ulcer prophylaxis is indicated in patients who are being mechanically ventilated. It's also indicated in burn patients to prevent Curling's ulcers, head trauma patients to prevent Cushing's ulcers, and lastly, those patients who have a coagulopathy as they're at high risk for bleeding. Peptic ulcer disease refers to both duodenal ulcers and gastric ulcer disease. Keep in mind that endoscopy is the key to diagnosis and treatment. The most common causes in the United States are H. pylori and NSAID abuse. One area that people get tricked up on is that alcohol and tobacco don't cause ulcers, they simply delay the healing of ulcers. Some more or less common causes are, as we discussed, burn patients, head trauma patients, those with Crohn's disease, as these lesions can occur anywhere in the alimentary tract, gastric cancer patients, and those with gastrinomas, such as Zollinger-Ellison syndrome. Remember, if you have NSAID-induced peptic ulcer disease, these are going to produce more bleeding than pain. There's no way to diagnose peptic ulcer disease without endoscopy. Here's an up-close image of a peptic ulcer in the stomach. Here's that same ulcer as histology. Peptic ulcer disease will present with recurrent episodes of epigastric pain. The pain will be described as dull, sore, or gnawing. If the patient states, "My pain is improved with eating," this is likely a duodenal ulcer. If the patient states, "My pain is worsened by eating," it is likely a gastric ulcer. Remember, since the pain is worsened by eating with gastric ulcer, these patients will also have weight loss. Upper endoscopy is the most accurate test for peptic ulcer disease. It allows for both intervention and biopsy. If you encounter an ulcer on endoscopy and the biopsy is positive for H. pylori, you must initiate antibiotic treatment. If you encounter a bleeding ulcer, you can place a clip or consider epinephrine injection to attain hemostasis. Radiologic testing, such as an upper GI series, has poor sensitivity and does not allow you to test for histology. Therefore, it is not a good test for peptic ulcer disease. Peptic ulcer disease responds to PPIs in over 95% of cases, but will recur unless H. pylori is eradicated in those who are actually infected. In a duodenal ulcer, H. pylori is associated with it 80 to 90% of the time. When it comes to gastric ulcers, they are associated 50 to 70% of the time with H. pylori. What you must keep in mind is cancer is present in 4% of those patients with gastric ulcers, but none in those patients with duodenal ulcers. If you're presented with a patient who has a biopsy positive for H. pylori, the best initial therapy is a PPI combined with clarithromycin and amoxicillin, or metronidazole and tetracycline. If they have a penicillin allergy, you can replace the amoxicillin with metronidazole. If they have a treatment-resistant ulcer, you can consider adding bismuth. Remember, 30 to 60 days post-therapy, you must test them for eradication. A 56-year-old woman comes to clinic with epigastric pain from endoscopically confirmed duodenal ulcer. She's unresponsive to several weeks of PPI, clarithromycin, and amoxicillin. What is the most appropriate next step? Should we refer her to surgery, switch the PPI to ranitidine, get an abdominal CT scan, consider capsule endoscopy, urease breath testing, vagotomy, or add sucralfate? The correct answer here is E, urease breath testing. If there is no response to therapy with PPIs, clarithromycin, and amoxicillin, the first thought should be antibiotic resistance of the organism. Persistent H. pylori infection can be detected with several methods, such as urease breath testing, stool antigen detection, or repeat endoscopy with biopsy. It would be very hard to choose between all of these. That's why they're not all given as choices in the question. Now let's go through the wrong choices. Referring to surgery was done before we knew H. pylori was the cause of ulcers. This is way too invasive. We would never switch a PPI to ranitidine because ranitidine is actually not as superior as a PPI. Abdominal CTs cannot diagnose H. pylori. Neither can capsule endoscopy. A vagotomy also is a little too invasive for treatment of a type of ulcer, and if it's due to H. pylori, it's definitely too invasive. And remember what I told you earlier. Choosing sucralfate as an answer choice is always the wrong answer. If initial therapy doesn't resolve a duodenal ulcer, then detecting persistent H. pylori and switching the antibiotics to metronidazole and tetracycline is appropriate. You can also add bismuth. For those with refractory gastric ulcers, a repeat endoscopy is done to exclude cancer. Reasons why treatment failure occurs: non-adherence to medications. Remember, it's 14 days of antibiotics, multiple times per day, alcohol use, tobacco use, and NSAID use. What's the difference between a gastric and a duodenal ulcer? Gastric ulcer pain is more often worsened by food. Gastric ulcers are also routinely biopsied. We also routinely repeat the endoscopy to confirm healing of a gastric ulcer, and gastric ulcers are associated with cancer in 4% of people. Non-ulcer dyspepsia, or functional dyspepsia, is epigastric pain that has no identified etiology. The pain can be identical to gastritis, peptic ulcer disease, gastric cancer, or reflux disease. Non-ulcer dyspepsia is the most common cause of epigastric pain in the United States. However, the underlying cause is unknown. Remember, non-ulcer dyspepsia is epigastric pain with a normal endoscopy. Now, the best initial therapy is with PPIs. However, there's a small caveat here. If the patient is less than 45 to 55 years of age, we treat empirically with PPIs and scope only if symptoms do not resolve. For those who are over 45 to 55 years of age, the actual treatment is PPIs and an EGD to rule out cancer. If dyspepsia is present in this group, along with dysphagia, weight loss, or anemia, it must be done immediately. Keep in mind that non-ulcer dyspepsia is definitely not associated with Helicobacter pylori. However, if symptoms do not resolve with initial therapy and H. pylori is present, you must consider treating for H. pylori. When presented with a patient with a gastronoma or Zollinger-Ellison syndrome, you want to look for patients with ulcers that are of the following characteristics. The ulcers will be large or greater than 1 centimeter. They will be multiple. They will be past the third portion of the duodenum. Remember, normal ulcers, it's very uncommon to be there. They will present with diarrhea. They have diarrhea because acid inactivates lipase. They will have abdominal pain, anemia, and heme-positive stools. After endoscopy confirms an ulcer, you can correlate it with one of the following 3 points. The first, if they have high gastrin levels with an acidic stomach, even though they're on PPIs and H2s, that is common with gastronoma. If they have high gastrin levels despite a high gastric output, that is also consistent with gastronoma. Remember, high gastric output should negatively inhibit gastrin levels. And lastly, if they have a high gastrin level despite injecting secretin, well, this is very confirmatory as it's the most accurate test. A secretin stimulation test will inject secretin. As secretin goes in, you're supposed to expect gastric output to go down. However, with patients with Zollinger-Ellison syndrome, despite injecting secretin, as time progresses, the amount of gastric output levels continue to rise. What's the next best step after diagnosing Zollinger-Ellison syndrome? You want to exclude metastatic disease with a somatostatin receptor scintigraphy and endoscopic ultrasound together. Why? Because gastronoma is associated with a massive increase in the number of somatostatin receptors in the abdomen, and EUS can pick up lesions in the pancreas. Here's a tip for you. Ultrasound, CT, and MRI of the abdomen have poor sensitivity and are never the most accurate test for diagnosing ZE. How do we treat them? Well, local disease is removed surgically. However, if they have metastatic disease, they're going to require lifelong PPIs to block acid production. A 64-year-old patient with diabetes for 20 years comes to the office with several months of abdominal fullness, intermittent nausea, constipation, and a sense of bloating. On physical exam, you hear a splash over the stomach. What's the next best step? Well, should we get a CT, perform a colonoscopy, give him erythromycin, an upper endoscopy, or a nuclear gastric emptying study? The correct answer is C. When the diagnosis of diabetic gastroparesis seems clear, there's no need to do diagnostic testing unless there's a failure of therapy. Erythromycin and metoclopramide are prokinetic agents that can increase gastrointestinal motility. Let's go through the wrong answer choices. An abdominal CT scan really can only diagnose static conditions. It won't tell us how the stomach is moving. A colonoscopy, well, it's kind of the wrong end. An upper endoscopy won't reveal anything. It might have retained food, but that's not specific for gastroparesis. And a nuclear gastric emptying study, though it is the most accurate test, it's rarely needed. When you have long-standing diabetes combined with the autonomic neuropathy that results from a high glycemic index, you get resultant dysmotility from an inability to sense stretch in the GI tract. The distension of the stomach and intestines is normally the most important stimuli to motility. In patients with gastroparesis, they have dysmotility. This will lead to nausea, vomiting, and early satiety. All these together is known as gastroparesis. The patient's most common complaint is abdominal discomfort with eating large or small meals. They will have nausea and vomiting, bloating and constipation. These are considered the upper and lower symptoms. The patients will have anorexia or an aversion to eating, and early satiety because their stomach is always full. These are the resultant neurologic symptoms. The patients on endoscopy will have a large amount of retained food, and on exam they'll have a succussion splash. This is a fluid wave in the stomach. These are the signs that are elicited by exam in diabetic gastroparesis.